Good morning. My name is Dr. Kevin Ford. I'm a member of Omega Psi Phi Fraternity Incorporated, Gamma Pi chapter located in Prince George's County, Maryland. And this is our monthly health webinars where we discuss topics that affect our community. And today's topic, we're going to be discussing a lot of women's health issues. And we have a special guest today. We have Dr. Brother Christopher Plummer. And Dr. Plummer is a board certified physician in obstetrics and gynecology. He went to medical school at New York College of Osteopathic Medicine. He did his residency at Nassau University Medical Center and his fellowship in maternal fetal medicine at Pinnacle Health Hospital in Harrisburg, Pennsylvania. And we have here Dr. Plummer. Welcome, sir.
Hi, how you doing, Brother Ford? Glad to be with everyone today. It's the end of the Black Maternal Health Week. And I'm glad to be here at the seminar and answer, questions and have a robust discussion today.
All right. And so I think we're just going to go through, multiple topics today, just kind of a fireside chat. And hopefully we'll also get some questions from the audience. Okay. Well, one of the things I wanted to go through first was screening. Mm-hmm. And we know women get cervical cancer.
Yeah.
So I know there's been some changes as far as when women should get screened. If you can kind of go through that with us.
All right. I mean, cervical cancer in the United States is probably one of the most, preventable and detectable cancers that gynecological cancers that we have here in the United States due to the Pap smear. All right. Now, the Pap smear kind of has changed throughout the years due to technology. So generally with testing and HPV testing, we usually recommend starting Pap smears at around the age of 21 for their first Pap smear. And then that Pap smear, since it's what we call liquid-based Pap smear, it can be done usually every 3 years if there's no issues, with their Pap smear. Also with HPV testing, sometimes it can be done with every 5 years, but that isn't usually with a discussion with your gynecologist. But if there is some abnormal cells noted with their Pap smear or their Pap smear is abnormal, then what they will do is go to another test, which is called a colposcopy, where you would look at the cervix under a special microscope and then look for any abnormal changes to the cervix and then do a biopsy. And then also take a sample of the cells within the cervix with a certain brush or scraping, and then they will take a look at the biopsies to see if there is any signs of any severe dysplasia or anything that could lead to cancer. And then there's other treatment modalities such as removal of a certain part of the cervix, either through a leap or a cone. And if there is actual, cancer, it depends on their age and about how the issue with childbearing on how that would be managed. But again, Pap smear has actually made cervical cancer one of the most detectable gynecological cancers that we have here in the United States.
And so, Dr. Plummer, you mentioned a couple different things, and I want to just clarify it for
Yeah.
the audience that we have. HPV. What's HPV?
HPV is a human papilloma virus. It causes genital warts. Also, it can cause changes within the dividing cells in the cancer. In the cervix, which, if untreated or unrecognized, can develop into abnormal divisions of the cells, which would cause cancer. The most common cancer, one of the most common HPV types that can cause cancer is 16 and 18. And that's now reducing now because of the vaccine, which I guess we also talk about, which is a part of screening, which is available for young boys and girls from the age of 9 to about 26, but they're also extending it with the vaccinations up to age 45 with discussions with your doctor.
So really, this human papilloma virus, or HPV, that's a big cause of cervical cancer. That's what I'm hearing, right?
Yeah, yeah. That's one of the largest causes of cervical cancer in the United States.
Right. And so by getting this vaccine, getting our kids, people you just mentioned, anybody from age 9 up until 26, those are the main people that they're doing it, but then you can extend it out, some people to 27 to 45.
Yeah.
So if you get vaccinated against HPV, that can almost eliminate your risk of getting cervical cancer.
It'll eliminate the majority
Majority.
the majority of it, at least 90% or greater
Right.
of cervical cancer, because most of cervical cancer is usually a squamous um, cancer, but then there's some that are in the endocervical cells, but those are usually more rare. But the majority of cervical cancer can be prevented with vaccination and also screening.
Right. So that's so important to have our your mom, your sister, your
Yeah.
uh any woman in your family to make sure that they're getting their pap smears.
Yeah,
Now,
I think sometimes there's a stigma with the vaccine, thinking that if they get the vaccine, they would become more sexually active, and that is just not true. That is more of a preventative thing along the line to prevent them from developing cervical cancer or head and neck cancer, throat cancer, esophageal cancer, anal cancer due to the HPV virus.
right. So also when we talk about pap smears, we say that you can stop at a certain age in
Yeah.
certain circumstances. And what is that? What age is that?
Well, I mean, we look at about if the age of 65, if you had a normal trend of normal pap smears, a recommendation is that you can stop doing cervical cancer screening, because the risk of you developing cervical cancer, especially at that age, and also with a history of normal pap smears, is very low. Also, if you have a total hysterectomy, which is removal of the cervix due to reasons for fibroids or due to reasons of of heavy periods, and you have a hysterectomy just simply for that, and everything else is normal, and there is no history of any abnormal pap smears or any suspicion of cancer, then usually they would stop doing pap smear screening for cervical cancer.
Right. And also understand that even though we say you can do pap smears every 3 years, some say 5 years in certain situations,
Mm.
but there are certain patients that need pap smears more frequently.
Yeah.
People who have HIV
Okay.
disease or
Mm.
have had history of cervical cancer or even weaken immune systems, and they may need more frequent. So,
Yeah.
it just depends. You got to make sure you talk to your physician,
Yeah. I mean,
obviously.
everything that we say is really on the caveat of following up with your physician, because your physician knows your underlying issues more than we're talking on a webinar.
Mhm. And so, other screenings that we encourage women to do, obviously, is breast cancer,
Mhm.
and when would we recommend women to get their mammograms?
Well, breast cancer is a very a large majority of women. Usually, they say 1 in 8 will develop, breast cancer. So the screening now has been brought down to some women will start having, mammograms at the age of 40. Before, back in days, used to be 50, but we've seen that women have been developing breast cancer even earlier. So just like we've seen the change in colon cancer screening, of doing it younger, we have also seen that with breast cancer, of getting their mammograms. Now, mammograms sometimes at the age of 40, some women have dense breast tissue, and sometimes the mammogram may not be as effective. So sometimes they might also do, if they feel a lump or something, also do a breast ultrasound.
Right.
People that are extremely high risk of having breast cancer, that have genetic mutations or a strong family history of that, they've also been including a breast MRI.
Right.
That is not, breast cancer is not my particular specialty, but those are the other screening modalities that are out there for breast cancer.
Right. Now, another topic, ovarian cancer.
Mhm.
Um, you know, what the thought on ovarian cancer and screening, quote unquote.
Well, unfortunately, there's not a real good screening test for ovarian cancer. And unfortunately, by the time people are diagnosed with ovarian cancer, it's usually about at stage 3 of ovarian cancer, when it's starting to be pretty advanced. And the subtle signs of ovarian cancer, is bloatingness, pelvic pressure, sometimes GI issues, which are very subjective and very general. Um, Now, if the person has a family history of ovarian cancer, or have genetic mutations, which we'll discuss in a little bit later, then those are going to be having more screening. Then there's a discussion, if there's a real strong family history or genetic mutation, if they're done with their childbearing, um, then to do a hysterectomy and also remove their ovaries. Now, one of the things that we found to be protective of with ovarian cancer are birth control pills. So women that are at a high risk of having ovarian cancer, if they take um, birth control pills for a certain period of time between their pregnancies, and then after they're done with their childbearing, do a hysterectomy or removal of their ovaries, can reduce the risk of them developing ovarian cancer.
Wow. So that's important, especially women, who you said have higher risk.
Yeah,
Right? And those higher risk people like you said, genetic mutations,
yeah, the
BRCA1, BRCA2
BRCA2
genes,
genes.
Lynch syndrome,
Yeah,
right? Or just a high risk of family members with mother, sister,
uh,
grandparents, aunts
yeah.
who have ovarian.
And
Okay.
also, screening can be also individualized, especially if they don't have a known mutation. Some people will bring them in for ultrasounds every year or so, but that's an individualized management with their GYN provider.
Right, right. So, we kind of touched on a lot of screenings, and maybe some we may mention a little bit later, but we're talking OB, right?
Yeah.
And there's different um, methods of delivering babies, and if you can kind of just go over some of those.
Oh, methods of delivering babies.
Yeah.
Okay. Well, I mean, uh, for centuries, people women have been delivering babies vaginally. Obviously, we also deliver women by what we call cesarean sections, which, is kind of, they think that, Julius Caesar was delivered by a cesarean section, but generally by the history of cesarean sections, especially back in those days, it usually would be fatal for the mother. So it was questionable because Julius Caesar's mother lived after he was delivered. So it's questionable if he was delivered by a cesarean section. But any which way, cesarean section is also a mode of delivery through the abdominal area, through an incision through the abdomen and through the uterus, and delivering the baby, which is also a common obstetrical procedure that is done, now in the United States, quite frequently.
Right.
But again, those are the two modes of delivery.
Right.
Um,
And there's also some alternative birthing methods.
yeah.
Can you kind of
Yeah,
expand?
we could talk about that. Well, I mean, throughout the centuries, you used to deliver at home, all right, and that was the way of childbirth, and they were delivered by midwives, and they were delivered in a circle of family, and that was the mode of delivery. Now, also, most people now deliver babies in hospitals, and the hospitals are also good because they can also manage complications of childbirth, such as hemorrhage. After the baby's delivered, the uterus needs to clamp down in order to stop bleeding. Now, in cases that of postpartum hemorrhage, sometimes uterus doesn't clamp down. Sometimes there are um, lacerations and bleeding that happens, and usually about 20% of the blood flow, especially to a term uterus, is of the blood volume goes to the uterus. So if the uterus doesn't really clamp down and stop the bleeding, a woman can bleed out within a matter of minutes. So having the preparation of being in the hospital to get medication and also to get emergency blood and blood products is very important. Again, that's the benefit of hospital births. And also, if there's an issue with the baby after it's delivered, are people around to do what we call neonatal resuscitation. And if the place has a NICU, also to manage the newborn in those cases. Now, there are people that deliver at home, and if they really are low risk and uncomplicated, and they understand the risk of home birth, I think they have a very good experience because they're surrounded by their family members. They're surrounded by a person, usually a midwife, that is caring and giving their attention, and they feel that their needs are being met. And also, when you feel that your needs are being met and you're in a more comfortable setting, there's less stress with the delivery and more, bonding with the baby and their family during that moment.
Okay. So people also talk about, water births.
Yeah.
What's your
Well, I mean, water births, I guess, for low risk, patients, they can do that. The American College of Obstetrics and Gynecology yet finds, delivery as itself in the water. The evidence is still inconclusive, so they do make the recommendation of delivering on land and not in the water. But the first stage of labor, especially before they become fully dilated, being in the water gives them a lot of more comfort. There's less need for pain medication. A lot of them feel more comfortable during that stage of laboring in water. But again, delivering in the water, there could be an increased risk of infection. Sometimes the baby might aspirate the water as it's delivering. That those are certain complications, but it all depends on if they're willing to accept the risks, and if they're pretty much a low risk patient, they have a very good experience doing a water birth.
right. So your specialty is high risk pregnancy.
Yeah,
Is that correct?
yeah.
So what makes a woman high risk as far as when they're pregnant?
Well,
What
I
makes
mean, as in when they're pregnant, high risk pregnancies are usually ones that have usually a medical condition associated with that. You know, high blood pressure, diabetes, thyroid issues. If they have a history of a stroke, history of a blood clot, history of adverse pregnancy outcome as a stillbirth, or had issues after delivery, postpartum hemorrhage. Those are usually ones that would be seen, and also teen pregnancy and obesity is also a big epidemic in the United States. So those pregnancies also can have complications of having preeclampsia, which is elevated blood pressure in pregnancy, and also gestational diabetes.
Mhm. Is age a factor?
Age is a factor. Usually, once they become 35 or older, is considered, we call advanced maternal age. There's an increased risk of having a fetus with a chromosomal abnormality, usually Down syndrome. Generally, at the age of 35, some of the medical conditions, such as high blood pressure or diabetes, is also present, and also they can also develop preeclampsia or gestational diabetes in the pregnancy compared to a younger woman.
Mhm, mhm. And nowadays, so as women are getting having babies later,
Yeah,
and IVF is here, and everyone's heard about all the controversies that's going on in the news about that.
yeah,
Um, I think women will get their eggs saved, and
yeah.
yeah,
I mean, that is a new trend now, because a lot of women are getting their education or getting their lives together. And what happens is the older you get, the your fertility rate starts to go down. So a lot of them will harvest their eggs and freeze their eggs, and then once they find their partner, their life partner, then they
mhm,
would get them fertilized and then implanted. And also, when you also have in vitro fertilization, you probably also should be seeing also a maternal fetal medicine specialist. And generally, if you have any medical conditions and you're thinking about becoming pregnant, you can talk to your OBGYN about referring you to a maternal fetal medicine specialist, so we can talk about how to optimize you before pregnancy. Because usually what it happens is usually see people when they're already pregnant and they already have these complications. They said, oh, I was in heart failure, just a few months ago, or I have uncontrolled diabetes, or I have uncontrolled high blood pressure, or a thyroid issue. So meeting a maternal fetal medicine specialist, earlier, because usually majority of pregnancies in the United States are unplanned. So it's a good idea if you're able to do that, to meet with a specialist, so we could try to optimize, make sure you have all the right vaccinations, make sure that you have your diabetes under control. If we would like your hemoglobin A1C to be down to be 6 or less before you get pregnant, just to reduce developmental complications in the fetus, and also you will have usually a better outcome when your diabetes is more controlled in the early part of the pregnancy. Also, making sure that your blood pressure is, well controlled, and we address other medical issues that could be an issue during your pregnancy.
right, right. And so hemoglobin A1C, that's a test that we use
Yeah.
to assess someone's whether their blood sugar is
Is
under
well
good
controlled,
control
and
or
I
bad
and
control.
ideally we usually get that in the beginning of the pregnancy, because we like to know, because it's predictive of your control at least about 3 months prior. So
Right.
when you come back into early pregnancy and we do the hemoglobin A1C, and it's really out of control, then it really can increase the risk of the baby having malformations
Mhm.
during the pregnancy, especially if you have really uncontrolled diabetes.
Right. So the bottom line to all this is if you thinking about having getting pregnant,
Yeah,
to make sure that you go and talk with the maternal fetal medicine physician
If you have issues,
medical
you
issue.
can first
You have medical
start
issue.
with your OB provider, GYN, and said, "I'm thinking about getting pregnant." So then they would start the wheels going. And if you really have no, issues, then that's fine. If you do
Right.
happen to have issues, then you could be referred to a maternal fetal medicine specialist that can do a consultation, either virtually, like we're doing now, or you can definitely come into the office and talk face to face.
Right. Right. So after women have their children, sometimes they become depressed. It's
Yeah,
called postpartum depression. Can you
yeah.
tell us about that?
Well, I mean, women will, I mean, about 70% of them will have some issues, some things that are down because having a child and that you're taking care of is it could be very, very stressful. It's a very great moment, but the sleepless nights or the baby, crying, it depends on how much support staff you have at home because some of them are just really sometimes by themselves and managing all that can be very, very stressful, and some women do develop postpartum blues, and also maybe greater than 10% might develop what we call postpartum depression.
Mhm.
And postpartum depression can lead to postpartum psychosis, where the woman will could possibly kill herself or the baby, and those are things to be recognized. So when they come in for any type of postpartum visit, they usually fill out a questionnaire to see how you're doing, how much sleep you get, are you crying excessively, and then they come up with a composite score to see if you have, postpartum depression, and sometimes they could be referred to a specialist, one to talk to, and if you need to go on medication, that you can. Now, some people might already be in a situation where they might already have depression already,
Mhm.
and some doctors will give them medication, usually what they call SSRIs like Prozac or Zoloft, that they can take um, during the pregnancy, which is also safe to take during the pregnancy, especially in the later part of the pregnancy, because you want to get to a certain level of your anxiety and also your depression to be controlled, so to reduce you developing postpartum depression after delivery.
Right. Right.
All right.
And so that was, yeah, you're important about the
Yeah.
screening and
Yeah.
making sure that, a lot of times I was hearing that patients, when they bring their child to their pediatrician
Mhm.
for their 1 month visit,
Yeah.
2 month, 4 month, 6 months visit, a lot of times the pediatrician will give them those um,
Questions too, because
question
yeah,
and answer. Yeah,
because what to tell you the truth, they'll probably see the pediatrician a lot more than the actual obstetrician,
exactly.
especially after the baby's delivered, and they need to do their follow up. So it's usually a joint thing to see if they're recognizing any signs of postpartum depression in the mother, also to protect the infant too.
Child. Yeah.
So
Yeah.
those are important factors. There is a medication called Xarelto. It's an IV infusion that they do over 60 hours in the hospital for people that have real severe postpartum depression. It's a newer medication that is usually done in concert with their obstetrician and also their mental health, provider.
Hmm. Okay. So that's relatively new.
Yeah, so it's
Yeah.
relatively
Right. But
new,
that's
new medication.
primarily for severe
Well, usually
postpartum.
for severe postpartum depression, I mean, for to put someone in the hospital for 60 hours to get an IV infusion is usually for a more severe postpartum depression.
Okay. So we've kind of talked about the whole gamut of pregnancy, some of the complications that can happen. There are other things that can happen in women when they're having a baby, also. You're talking about, you mentioned preeclampsia, and I'm not sure if you, uh,
Yeah, preeclampsia, and we don't know, what, because we only see it in pregnancy. It's when a woman has elevated blood pressure and spilling a protein in the urine. That is usually the baseline of that. Now, the good portion of it is usually done is usually seen in the third trimester,
Mhm.
late in the third trimester, because the only cure for preeclampsia is delivery. Now that becomes an issue when you have preeclampsia very early in the pregnancy, because the only cure is delivery, and delivering a premature baby has its own issues that we'd like to avoid.
Mhm.
So there's different types of preeclampsia. There's preeclampsia with mild features that we can manage and continue the pregnancy, and there's also preeclampsia with severe features where they start to have elevated blood pressure to really high levels that need medication. They also can affect your liver. They can also affect your blood clotting, properties. They can also affect the growth of the baby,
Mhm.
and also can lead to what we call eclampsia, which is seizures. And obviously, once you reach eclampsia, there is a high risk of maternal mortality and also mortality for the baby. So, therefore, no matter what gestational age, when you have eclampsia, the recommendation is for you to be delivered. Women that are at increased risk of developing preeclampsia are ones with high blood pressure, especially uncontrolled, diabetes, which is also especially when it's also uncontrolled. um, Women that have renal disease are at increased risk of developing preeclampsia. A woman with a history of preeclampsia is also increased risk of developing preeclampsia. Again, um, we've tried a lot of things to help try to prevent it. Of course, controlling blood pressure, controlling diabetes. We also recommend low dose aspirin. From what we're able to see, can help reduce the risk of preeclampsia. But those are the reasons why, if you really have underlying medical issues, that you probably should see a maternal fetal medicine specialist in the beginning of the pregnancy, so we can follow you closely with during your pregnancy, just to help manage if you develop preeclampsia, especially early.
Right. Right. So that was one of the things in OB I remember about OB is preeclampsia and eclampsia. I mean, that's
Yeah,
something that is a critical. You have to make that diagnosis.
yeah.
Definitely, definitely. Well, we're gonna switch it up now, I guess, and I'm gonna talk a little bit about menopause. I mean, we have
Oh,
a
yeah.
lot of women who are in their mid years who have menopause, and so what menopause basically you don't have a menstrual cycle
Yeah.
at least 12
for
months.
for for about for about 12 months.
That's
I
right.
mean, there are the labs like a FSH level that if it's extremely high, then that's usually what we'll diagnose as menopause. I don't substance say, all right, if you're completely in menopause for not having a period for over a year, because I've seen some pregnant women come back and say, I haven't had a period for a year, but now
Now they're
I'm
pregnant.
back and I'm pregnant. So obviously they somehow they ovulated, but generally the diagnosis is not having a menstrual period for over a year. But some people will confirm it with certain during certain hormone levels,
Mhm.
just to confirm it. Yeah.
Right. So when the women are going through menopause,
Mhm.
um, it's usually because their ovaries aren't
Yes.
making.
Yeah.
Uh,
After, I mean, as a fetus, there's millions of eggs that are in the fetus, and then by time they're delivered, there's maybe about 300. By the time they get to puberty, about 300,000, and by the time they start to do the ovulation, their eggs usually will start to deplete. They usually talk about 45 or 50, and after that, then they don't really produce as much estrogen anymore, and those that lack of and drop in estrogen can cause vasomotor symptoms such as hot flashes, palpitations, um, things like that.
right. Um, Their mood can be affected also.
Yeah, it could affect mood swings. They call it the change.
Right. Some
Um,
women get real severe vaginal dryness, which can
yeah,
make them uncomfortable when they're having sexual relations. Um, so that can be very, a lot of women come in and usually they're about what, 40s, in their late 40s, early 50s,
yeah,
when they have start to have menopausal symptoms. And so the question always comes up in my office, okay, doc, what are you going to do for me?
yeah,
Right. And so we used to give years ago a
yeah,
lot of estrogens.
yeah.
Okay. Uh, but we found out that the estrogens can cause increased risk of breast cancer, endometrial cancer, increased risk of blood clots, increased risk of stroke. So we try not to give those estrogens unless, it's the last thing that
Can give. Some
give
people
there.
just treat the vasomotor symptoms with medication such as the palpitation and hot flashes.
Mhm.
Um, some of them do take can take estrogen. The only thing with estrogen, especially when it's unopposed, is especially and you still have a uterus, can increase the risk of uterine or endometrial cancer.
Right.
So that was an issue, and then we had the um, other combined um, estrogen and progesterone combinations, which also brought an increased risk of blood clots
Mhm. Mhm.
and cardiac issues. Each one has to be individualized with your doctor about how to treat that.
Mhm.
But that's I don't deal much with menopause
Yeah.
anymore. I deal with the other aspect.
They have some non-hormonal besides the estrogen and estrogen
Yeah,
to give patients some of the
patience.
non-hormonal things that we do. You
Mhm.
mentioned before about the antidepressive medicine,
Yeah,
the SSRIs.
yeah,
And so only paroxetine, which is Paxil, is the
yeah.
only one that's
Mhm.
actually been approved by the FDA
Mhm.
to treat menopausal symptoms. And so that's one of the treatments that we can help to try to help with some of the vasomotor symptoms. The other thing, there's some off-label ones that we try to give too sometimes, such as
Just excuse me 1 second. I'm on call, so I got to answer some
okay,
phone
I'll
call. Go
keep
ahead.
talking about this while you're off. But what some of the other what we call off-label treatments for menopause, we can give some patients what's called gabapentin, which is helpful for not only treating uh, diseases for neurologic problems, but also to help out with pain. There's also a blood pressure medicine that's given called clonidine, and then also medication that we help to treat the bladder is called oxybutynin. But those are more off-label. The main non-hormonal medication that we use for menopausal symptoms is the paroxetine, which is also called Paxil. Now, also a lot of lifestyle changes. As far as lifestyle changes, you know, we try to get women to do more layered clothing because when they get these real hot flashes, they can take off layers at a time to try to help cool them. Um, I know in the evening, a lot of patients come in that a lot of fans they're using. Uh, we tell them to avoid spicy foods, alcohol, caffeine, because that sometimes can trigger some of these vasomotor symptoms, which you mentioned are like night sweats, hot flashes, increased heart rate, um, all of those things. There's also a newer medication that's not related to hormones that we can treat menopausal symptoms, and it's called Vioza,
Mhm.
and that helps to reduce hot flashes by like 50%.
Yeah.
So that's one of the newer medicines out that we can use for menopausal symptoms.
And what about bone? I guess you're going to go into
Osteoporosis, yeah,
osteoporosis.
right. But the other thing, even talking about menopause
Yeah.
and um, postmenopausal bleeding, right?
Okay, now, yeah, that is a big issue because the diagnosis for endometrial cancer, or one of the signs of endometrial cancer, and also maybe even ovarian cancer, is also postmenopausal bleeding.
And what is that? Just
So
kind of
generally, what is usually, as just as it's called, is like if you're in menopause and you haven't had any bleeding for, over a year,
for
and all of
menstrual
a
cycle,
sudden, you're having bleeding, then that it needs to be evaluated. And with that needing to be evaluated, is by generally either doing a biopsy in the office, or to be a little bit more thorough, going in the uterus with an actual scope, taking a look and removing tissue so they can be evaluated in the pathology to see if there's any signs or changes in the endometrial lining, which is suspicious for cancer.
right? Yeah, so that's definitely important. You have patients that hadn't had a cycle in a while, and they just say, "Oh, well, maybe my cycle's on."
Mhm.
They kind of don't mention it to you, but that's something that they want to be aware of. If you haven't had your cycle for over a year, and all of a sudden you have some bleeding, which appears to be like a menstrual cycle, you want to make sure that you tell
Get
your
that
physician
right.
so they can get you to the proper OBGYN to get evaluated. So that's a definite.
Just excuse me one quick moment. I'm sorry, Dr. Ford.
Sorry. So also, um, another topic is what's called osteoporosis. And so, what osteoporosis is that we our bones tend to we're not producing as much bone as we're losing, so our bones thin out. And so, when our bones thin out, that puts us at higher risk for uh, fractures or spontaneous fractures of our bone. It just depends on how thin your bone gets. Now, who needs to get screened for osteoporosis? Well, any woman over the age of 65 usually was sent for what tests called a bone density. And that's when they look at how dense or how thick your bones are or how thin. And that's what we're trying to find out, how thin are your bones. And so by doing this bone density test, we're able to assess whether you have osteoporosis, which is pretty severe, or what's called osteopenia, which is your bones are starting to thin. And so I mentioned um, any woman over the age of 65, but also men can get it. And so men, any man over the age of 70 should also try to get a bone density test. So that's something that's important. We know women that are in menopause or post-menopausal woman, if they have any kind of a broken bone without any actual trauma or falling or anything like that, they should be screened for osteoporosis. The other big thing, some people take prednisone, which is a steroid. If you're on long-term steroids, then you really need to be screened for osteoporosis also. And when they say long term, if you're taking steroids for greater than 3 months. And so what can happen is your bones start to thin. And so you can get just spontaneous fractures of your spine. You can get, of your hip. So it's important that we screen you for that. And then also a group of patients that need to get screened for osteoporosis are what we call perimenopausal women who are just now starting to miss their menstrual cycle. Their estrogens are just starting to go down. Uh, and also menopausal women whose body weight, they have a low body weight. They're
Yeah.
very thin with their BMI less than 20. Um, so those are people that we really recommend to try to go and get screened for osteoporosis. All right. And a lot of times we also recommend that patients take some calcium, some vitamin D when you have osteoporosis or
And,
osteopenia
and weight bearing exercises just to
and weight.
help um,
Exactly.
help strengthen the bone. I think there was a question. We had a question about any natural remedies. I think what you were talking about, or lifestyle changes that can reduce some of the menopausal symptoms. Um, Obviously, um,
Well, yeah, I think I talked about some of them. And
yeah,
some people also even talk about soy products,
products, yeah.
right?
Um,
Soy products
and
is
some
some,
people do have an allergy also to soy too. So
right?
that's but yeah, soy products have can also do that. Exercise, meditation, even
Mhm.
those type of things, for like stress relief, can also help, with some of the menopausal symptoms.
And the menopausal symptoms, they can last anywhere from 4 to 10 years,
Yeah.
and some people longer. Some people some people have it varies from patient to patient. Some women don't have any menopausal symptoms, so the vasomotor symptoms that we talked about, the hot flashes, the night sweats, and all of those things. Whereas some, I mean, it just becomes unbearable. Um, so everybody's a little bit different. But I think I went through the try to avoid spicy foods, try to avoid, a lot of alcohol and caffeine, wear layered clothing. Um, and those are some of the things I think that they mentioned.
Yeah.
Yeah. And we talked about when we're going back to osteoporosis, there are treatments for osteoporosis that can help to try to build up your bone. Because if your bone starts to be really thin and you are at higher risk of getting a fracture,
Mhm.
uh, then there's medication, there's some pills we can give you. They've heard of biphosphonates, which are like Fosamax, or there's some other ones that there, Lindronate, which is same as Fosamax. And you really try to treat the patient for about 5 years, and then you give them a break. Then there's also some medicines that you can give, injections that you can give every 6 months or so to try to help to uh, improve the bone health. Anything to add to that, doctor?
No, I think that's pretty good. I don't have much experience on that end anymore, with menopause. Pretty much all my patients are pregnant.
Right. And one of the things too we're talking about, let's see, just in general, just screening. Now we went all the way from pap smears for 21-year-olds. We went to menopausal symptoms for our older patients. But going back to not even just younger patients, but even anyone,
Yeah.
is STI screening,
Oh yeah,
right?
yeah,
STI screening, because that
um,
also
yeah.
in pregnancy.
Can also be an issue. We're starting to see an increase in syphilis. Believe it or not, now syphilis has gone in some places up, 200%.
Mm,
With the infection of syphilis. Now, the good thing about with pregnancy is that usually there universal screening for syphilis, HIV, hepatitis B, some places hepatitis C, and also gonorrhea and chlamydia. So generally, when they're pregnant, they usually get a whole workup for STIs. So the detection of syphilis in the early part of the pregnancy and proper treatment can reduce the transmission of syphilis to the baby.
mhm.
So that is one of the good things about, especially when you come in early for your prenatal care, you usually will get screened for all these STIs.
And
But
so,
yeah,
do they do that just once, or
well, they do that one. It all depends on the area, and the prevalence in the area.
right?
So sometimes they will also repeat it later on in the third trimester, repeat certain screenings. But generally, at least there is at least one initial one, and
Baseline,
it
right?
depends, and it then depends on the prevalence in the area. Some people will be screened again in the early third trimester.
Right, because it's not like they can't get it after they
Oh
got
no,
to
no,
spend it one time.
definitely hair kicking. But you know, it's all based on risk factors and the
Sure,
prevalence in
sure,
in the
sure.
area. But yeah, some people might test for it twice, maybe even three times, depends on the situation.
Right. So that definitely is something STIs, and then also like chlamydia
Yeah.
or that.
Chlamydia and gonorrhea, those are the ones that, especially if a woman is not pregnant, can cause a lot of inflammation called pelvic inflammatory disease.
Mhm.
That pelvic inflammatory disease can also damage the tubes of in the uterus as the infection comes up from the cervix into the uterus into the fallopian tubes, and then that can cause scarring. It can cause infection in the abdomen, and some women can get seriously sick or even die due to pelvic inflammatory disease, especially when it's not treated.
Right.
Also, when it's treated, it can cause scarring in the tubes. So when they do decide to get pregnant, some women have infertility issues or an increased risk of an ectopic pregnancy where the egg is now fertilized in the tube and is trying to make its way to the uterus, but due to the scarring of the tubes, it gets stuck into the in the fallopian tubes, and then it starts to develop. And if it starts to develop in the fallopian tubes, and it can rupture and cause a massive amount of bleeding. That is also, we call also called a ruptured ectopic pregnancy. So if we happen to see an ectopic pregnancy, obviously that needs to be treated with either medication or treated with surgery.
Right. And that's new. Well, since I got out of school,
Yeah,
because before all the topics were treated with surgery. Now it's
yeah.
medications. I think they use.
Medication called methotrexate, but it has to meet a certain criteria. But generally, if we find it early, we can give them a treatment of methotrexate, have them follow back. We'll follow their beta uh,
HCG,
excuse me, sorry,
beta HCG.
beta HCG down, to a certain level, and we will follow that, and then usually will dissipate, and then prevent a woman from undergoing surgery.
Hmm. So, how does health disparities affect women who are going through um, pregnancy and do you see any of that?
Well, I mean, health disparities has always been an issue, no matter what, but especially in pregnancy, because some of these women that they're not having access to medical care, and we've seen that a lot in the Black and Hispanic community. They're not exposed to healthy food choices, so a lot of the foods and things that they have are usually processed. So it increases the risk of high blood pressure, diabetes, obesity. So when you also have those health disparities, and when now you see them when they come in pregnant, they still have those issues. Still high blood pressure. I had a diabetic that I was just wondering why her blood sugars are not well controlled, and then she says, "Well, I live in a shelter or we live in a hotel, and the things that we have access to has to be microwaved, and there's not a lot of good food options and that we can afford." So I have to also think about that too. What can we do, least on to reduce health disparities? Is it going to be a political issue? Do you have to need to talk to your representatives about how we can get in our communities better, food choices, or better food options? Because that is going to be, or more clinics or more health providers in a certain area, because even in the rural areas, they don't have access to doctors as much as compared to in the urban areas. And
Right.
even in some of the urban areas, there's a lack of areas that they can get affordable health care. So the health disparities need to be addressed, so we can help reduce the risk of having higher mortality and morbidity seen in the minority community.
Right. Because that definitely still affects infant mortality. Definitely. Uh,
Excuse me, just 1 second. I'm sorry.
mhm. Yeah, when we're talking about infant mortality, um, how the mother is able to take care of herself also affects how the infant that is born. And so that's a big topic, health disparities and food deserts he was just mentioning. if you don't have healthy food options in your community. But the other thing is, if you can't afford it, he just mentioned that one of his patients lived in a shelter, and so that's a special circumstance. And hopefully, we can help to make sure those people will have be able to eat and try to eat foods that are healthy. And that's hopefully a real community issue. I know Dr. Plummer, he's on call today. He was gracious enough to still talk to us. Um, he's doing.
All right, sorry, I'm back. Unfortunately, I have to also.
I know.
There's a
I know.
patient upstairs that I gotta I have to go and see all of a sudden.
Yeah, so that's fine. But we're at the end, almost at the end of the hour anyway, Dr. Plummer, and I really appreciate you speaking with us today and imparting a lot of good knowledge about women's health. And I think we're going to let you go, and we'll sign off at this point. All right.
All right. Well, thank you, thanks, audience, for listening. Hopefully, I can impart some good information and good advice. We've always been talking about screening, seeing your primary care provider. That is always key. So we can try to reduce some of the health complications that you have, or manage that. Obviously, if you do happen to have medical complications, and you decide that you want to become pregnant, talk to your OB provider, and they will refer you to a maternal fetal medicine specialist, so we can have a plan on help reducing your medical issues, so you can have a very successful pregnancy.
All right.
All right.
Thank you again, my brother.
All right. Thank you,
Talk to
Brother Ford. All
All
right.
right.
Take
Take
care.
care. All right. Bye bye.